To introduce Dr. Sam Lam, who will share with us nuances of Asian blepharoplasty.
Thanks, Rami, for the invitation. How many people out here do Asian blepharoplasty? Okay, not a bad number. Now, don't worry, everyone else, you don't have to get up and leave. If you'd like to have a coffee break, you can, but this is going to be hopefully relevant for both those practitioners of Asian blepharoplasty and those who do not do that. First of all, we have to understand today, I really believe there's been a confluence of aesthetics, how we see the brow. You've heard some early lectures today about the shape, the fullness, and I think there is a uniform perception. However, one caveat is that I think that in the Asian, you don't want a very high crease. When you have that, it can look abnormal, and that's one of those telltale signs something was done. Where I think for the people in the room who don't do Asian blepharoplasty, there's going to be some intrigue is what do you do with that 55-year-old Asian woman coming in who apparently has dermatochalasis, but she has no crease, and you don't do Asian blepharoplasty? How do you approach her? Can you do something for her? Can you do a standard bleph? I'm going to address some of those in a very algorithmic fashion in the second half of this talk. In the first half is just how to do an Asian blepharoplasty, and hopefully that will still be relevant for you by maybe a few pearls. This is just a little illustration that shows that there is not an excess of fat. It's just the fat is sliding down, further down, because there is no adhesion of the levator muscles into the dermis. So I don't routinely remove fat unless it's going to prevent the adhesion of the fixation from the levator to the skin. So I generally don't like to hollow someone out because I'm an advocate of volume. There are different folds. This is in honor of my mentor, Dr. McCurdy, who's since passed away, and he has come up with different ideas of folds, but I really think the medium and large folds are antiquated ideas today because people are striving for as natural a result as possible. So I've never done a large fold. I rarely do a medium, and 98% of the time I do a small. I've done like one medium this past year. So these are just different shapes. So the upper one is a lower crease, inside fold with a slight flare configuration. That's my favorite design. And then the bottom one is a slightly higher crease with a parallel configuration or round design in an open inside. So first of all, we're going to talk about how to do this. You always want to mark the crease with the eyelid in retraction so that the eyelashes are in perpendicular orientation. So this is about 7 millimeters. I go 7 to 8 on the bottom. It just depends on where you want the crease height. And this is showing more of a rounded parallel crease, but inside with a little bit of an inside fold, which is what I prefer. Not too much flare. And this is just showing some retraction for my design. A little pearl for those people that do upper blepharoplasties, I like to not thread the needle because it causes ecchymosis. And if you have ecchymosis in an upper blepharoplasty and you're not worried about asymmetry, it's not a big deal. But when you're dealing with the Asian blepharoplasty, hematoma or ecchymosis can really cause some issues. So I just bleb it up. This is a 1 cc of half of Marcaine and half of lidocaine. And I just raise little blebs and then feed it with my finger. The other thing here is I also pre-numb them with some BLT or benzocaine lidocaine tetracaine before I start. It's important as you make your first incision not to go too deeply because you want to not get those arcades and just get the cautery, obviously cauterizing on the skin island side so that there is no damage to the skin surface. I take a little bit of preseptal tissue just along the inferior aspect, taking some avicularis and maybe a little bit of septum along the way. The trick here to avoid levator injury for someone maybe that doesn't do a lot of advanced oculoplastic work is I take my assistant to blot both sides on the lateral aspect of the wound until I start to see the fat, and I tease the fat through a small fenestration. Then I widen that fenestration going laterally, create a little bit of cautery just to make sure there's no bleeding from any orbicularis fibers there, and then just open. I usually like to open along the inferior aspect of this, and so that my fixation is uniform along the bottom portion of this. This is the clamping of fat, which I said I rarely do. Usually when I do this, it's someone with a lot of exuberant fat, as I mentioned, usually in the lateral department where it extends out there. And again, I know there's no lateral department, but it's just the excessive fat that goes out into the lateral aspect. This is a 5/0 nylon placed upwards, and then I run it across the base of the levator and then back up through the upper skin edge. I've tried all different types of fixation sutures, dissolvables, Vicryl. I found variable success with Vicryl. I used PDS, and the problem was the creases looked too deep in my hands. So I've gone back to this removable suture at 7 days post-op. And then you just want to see if there's about perpendicular reversion of the eyelashes as your endpoint. I put a lot of fixations, usually typically 6 to 8 per side. I don't think you can get enough fixation. In the past, I would use partial incisions, suture techniques, but there is a few problems with that. One is the fact that, in my opinion, an abbreviated incision is more visible than a full incision, and also when I really worry about having to use permanent sutures to hold this in place with a shorter incision line. And also, obviously, it gives me ability to modulate the extra skin by removing extra skin. For all those reasons, I love a full incision. I know it causes more recovery period, and that's what we're going to talk about next. This is just showing you a few weeks out on the middle one, about 2 weeks out, and this is about 3 or 4 months out. And there's a lot of edema. And this is showing you a week out, a lot more edema, and this is very typical for a full incision blepharoplasty. That's the biggest trade-off, is the recovery. So some of the things that I do to help my patients is I ask them, how many of your friends are white versus Asian? Because Asians know this procedure. White people, it just doesn't enter their mind oftentimes what this procedure is. So if there's a 25-year-old woman having an upper blepharoplasty, it's not fathomable as a normal procedure. So I tell them to wear a low glasses, very thick rectangular black glasses. That really helps mitigate any appearance of postoperative edema. And obviously any kind of eyeshadow, et cetera, that would help this. And for guys, it's a little bit harder, obviously. And also for guys, when they have a little bit of a higher crease, it makes things look off. Again, this is my favorite type of design. This is about a year out. Tiny, low incision, keeping all the fat preserved, a inside fold with a slight flare laterally. Same thing, about a year out. This is my favorite. It's a very low crease. And so some people, really want a much more defined, higher crease. I try to guide my patients toward aesthetics. They're allowed to have something that looks natural, but not something that looks unnatural. But I want to help them on an aesthetic basis of what I think would look good for them. So let's go back to this. This last part of the talk is going to be for people that don't do Asian blepharoplasty and are wondering, what do I do with this if she walks into your room and you don't do an Asian bleph? Are you going to turn her away? Are you going to do something for her? Where are the complication risks? So conceptually, I try to divide this into 3 categories to make it easy. Those that are born without a natural crease, for example, her. Those who are born with a natural crease, and then those who've had a man-made or surgical crease placed in the past. I'm going to show you my mistakes, because we learn from our mistakes and that's how we get better. So enjoy these. But this is the first one here. This is when I was doing more brow lifts and upper blepharoplasty. And I think I wasn't doing volume. This was many years ago. But the crease is too high. It doesn't look right. Now, if she were white, this would probably be acceptable, but I don't like this. Of course, there's a little bit of blepharoptosis along with that's underdiagnosed here. But this doesn't look right. So when do I take skin away from a person that already has a crease? That would be someone's, when the fold is actually at the ciliary margin or below it, or just at that very, very low level. And I'll give you one caveat in a moment. So if it's pretty high up already, you see a little perceived dermatochalasis and you take skin away, you're going to elevate the crease too high and it's not going to look right in my opinion. So this is again category 1, someone born with a natural fold. What do you do? Now there's one other caveat. When I say there's a fold, the problem is it's not an all or none proposition for Asians. Some have a full fold, some have a partial fold, some have no fold, some have a full fold on one side, a partial fold on the other side, and there are variable degrees of partialness. So here's the easiest way to categorize this. If they have any degree of a partial fold, they don't have a fold. That's the way I make it easy, because then they really fall into the next category, which is someone that doesn't have a crease. Or maybe the next one is, no. So the next one is someone that had a surgical correction many years ago. So she doesn't look too bad up high, but when I remove the skin, it all of a sudden looks way too deep, and it looks like brow skin folded on itself. This doesn't look aesthetically pleasing, and the reason for this is that back in the 80s, when this westernization procedure was much more in vogue, where high creases, excessive fat removal, skin removal was in vogue, the people had a very unnatural result for 20 years, and then it started to fall with brow ptosis, volume loss, dermatochalasis, and then what you do if you don't look underneath the fold is you make take too much skin away, and then they get this weird recurrence of what they had before. So I encourage you to ask them, have they had a procedure, when they had it, and then lift the skin up and take a look. So this is category 2, someone that's had a previous Asian blepharoplasty, typically a long time ago, okay? And so what do you do when they don't have a crease? There's several options. One option is just to make a crease. Well, this is not necessarily easy, because when someone is mid-50s, it's going to change their look, and it's also going to give them a decent recovery period. So here's how I make a decision. Well, first I counsel the patient. You know, this is how it's going to look. Do you mind the change in look? And this gentleman, I don't think I have any other options for him other than an Asian blepharoplasty. I don't think volume would help him. I don't think a brow lift will help him. And I think the mistake here is this is the thing that I want to caution you, is if someone comes to your office and they don't have a crease, don't just take skin away, because they don't really have a definable place to place that crease. If you do this, they usually typically have a scar that's visible, and they have so much pseudotosis, that is the absence of the fold, that they see no discernible improvement. So I encourage you, for this class of people that have partial creases or absent creases, not to go in there and just cut away skin. Sometimes you get away with it. Sometimes what happens too is you take a little skin away and you get some post-septal adhesions and you get a variable fixation, and that can even be better or worse. So just be cautious of doing this. So in this situation, I would either advise you to refer it out to someone that does Asian blepharoplasty, or you could try volume, but I think in this case it's so low that I don't think you're going to get away with it. This is an example where it's just fat grafting. It's just volume placed in there. And the key thing that I've been really understanding now is the volume loss in the intermedial brow. When you fill that little area, the brow just doesn't look ptotic anymore. And that's something I can explain to you separately, but it's outside the scope of this talk. So that's just volume, because the crease is sitting either at the ciliary margin or slightly above it. This case here, the crease is at the ciliary margin or a little higher, and you say, well, Sam, what you just told me you would never take skin away from a person who has a full fold, but it's a little bit above the ciliary margin. Well, conservative skin removal added with volume. So essentially what volume does, besides rejuvenate, is it maintains and lowers the crease position. Okay, so it actually lowers the crease position. So as the skin removal it goes up, it lowers it. So what if you take some skin away and you get a situation I showed you earlier where their skin is too high, where the fold is higher than aesthetically pleasing, and if you don't quite capture that psychologically or aesthetically of what is unpleasant, study models of Asian beauty and understand that a very high crease is not pleasant in today's society. So what you can do to fix it is lower it. You can use fat, you can use fillers, and again, really focus, whether you're dealing with a Caucasian or Asian person, look at that inner brow. I really encourage you, I don't take fat out of here unless it's really protruding immediately. I add volume back in. This is my mom, a little transconj bleph, but she's got some ptosis, high crease because of the ptosis, and just adding a little volume to lower the crease, give her some volume back, and then she looks a little better. A book, wrote Another Lifetime, and this is just understanding, again, fullness is really the key thing to have in terms of beauty and a low crease. And if you remember those 3 classifications of patients without a crease, patients with a crease, and patients who've had man-made crease, you can have an algorithm. And I wrote a clinics last year or 2 or 3 years ago that gives you the written algorithm of that. Encourage you to come in early September for a hair workshop, all hands on, St. Louis. I don't make any money on this course. I hope you guys can make it, and obviously the fall meeting coming up in October. I encourage you all to be artists. I encourage you to look at the face with an aesthetic paradigm rather than just a mechanical one. Thank you.